Welcome. It's my extreme pleasure to serve as the moderator for today's Ask an MS Expert webinar. I'm John Strum, and I'm the host of the Real Talk MS podcast. Each week, Real Talk MS reaches thousands of people in more than 90 countries around the world with the news that people affected by MS need to know. I'm also a non-scientist member of the International Progressive MS Alliance Scientific Steering Committee, where I work to ensure that the perspectives and priorities of families affected by progressive MS are represented in all of the projects and work undertaken by the Alliance. I'm a district activist leader for the National MS Society, and I also chair the Society's California Government Relations Advisory Committee. My wife, Jean, lived with progressive MS for 23 years, so I've had a front row seat experiencing all the ways that MS can impact a family. I'm thrilled to be with you today. People are continuing to join our webcast, so let's give them just another few seconds and then we will get started. Thank you to all of you who are joining us today on GoToWebinar, Facebook Live, and YouTube Live. Due to the large number of participants joining us on GoToWebinar, everyone has been placed in listen-only mode. Today's Ask an MS Expert webinar is one of a series of virtual opportunities the Society is committed to offering, so I hope you plan on joining us each week. Our objective in all of our Ask an MS Expert programs is to connect with you, share important information that you can rely on, and provide a forum for you to connect with experts on the topics that are on your mind. So as I chat with our expert today, please feel free to post your comments and questions as they come to mind on Facebook and YouTube, or type them into the question box if you're joining us on GoToWebinar. I have a helper working behind the scenes with me today. Kathy Costello is ready and waiting to capture your questions while I'm busy talking. We'll try to answer as many of your questions as we can during the Q&A portion of today's program. And I know many of you might have some very specific questions related to your own situation. Because of our limited time together, we're going to be focusing on the questions that pertain to everyone. And following the webinar, the Society's MS Navigator team will be standing by to address those specific questions that you might have. I'll be sure to let you know how you can reach an MS Navigator before the end of today's program. And if you're interested in reviewing today's conversation with our expert, this webinar is being recorded and it'll be available on the Society's website for your reference. No two people have the exact same set of MS symptoms, and each person's symptoms can change over time. Many symptoms of multiple sclerosis are referred to as invisible symptoms because no matter what sorts of challenges they may present to the person with MS, you can be standing right next to that person and have no idea about what they may be coping with. Our expert today is Dr. Heidi Maloni. Dr. Maloney is the National Clinical Nursing Director for the Multiple Sclerosis Center for Excellence East at the Veteran Affairs Medical Center in Washington, D.C., where she heads up research and programs to further the understanding of multiple sclerosis and its impact on veterans, while aiding in the development of treatments to manage the disease and its symptoms. Dr. Maloney specializes in managing pain and fatigue, which are two of the very significant invisible symptoms of MS, which we'll be talking about. Welcome, Dr. Maloney, and thank you for being with us today. You've been a leader and consultant in both the National MS Society and the International Organization of MS Nurses. You're also a certified neuroscience registered nurse, a certified adult nurse practitioner, and an MS certified nurse. And you've led successful campaigns to certify MS nurses internationally. And one of the areas I know you're passionate about is educating healthcare professionals around the comprehensive management of pain in MS. Pain is common in MS, and it's a very personal experience for an individual, one that they can feel, but others can't see. And pain can often limit someone's ability to do the things that they enjoy. So I'm hoping you can start our conversation by explaining the most common types of pain experienced in MS.
Thanks, John. Thanks a lot for that introduction. Pain is invisible, and being invisible, it robs the patient of their soul almost, the kinds of pain that we're talking about. So the types of pain that are very common for people with MS: headache, painful spasms, burning pain in the legs and the arms, trigeminal neuralgia, and back pain. These are the most common types of pain reported. Now, those pain syndromes can either be steady or intermittent. So they can be constant or they can come and go. And the type of pain that comes and goes is described by patients as being really, really sharp, lancinating, biting. And the kind of pain that is steady and constant is described as burning, nagging, maybe aching, maybe pins and needles. So people in the audience, you can understand when you have pain, you're recognizing some of the ways I'm describing it as tingling, or even itching can be a type of pain. Now, it's not necessarily painful, but it's nagging. And at the end of the day, that really gets you down.
John is one of our viewers, and he writes, "I get regular headaches and migraines and wonder if this could be related to my MS. Dr. Maloney, what do we know about headaches and migraines and multiple sclerosis?"
Headaches and migraines can absolutely be related to MS. In fact, about 60% of people that come for a new diagnosis also are suffering from headaches or migraine. Now, why is that? There are lesions in the brain that are responsible for pain. And there's a couple of articles that suggest that people with MS have lower levels of neurotransmitters, serotonin and norepinephrine. And these are feel-good neurotransmitters. And these are what is indicated in migraine. People with migraine utilize drugs that allow for more serotonin to manage their migraine. So yeah, John, migraine and headache is part of MS, or can be.
Are headaches and migraines that are part of MS, are they treated differently than they would be if it was simply someone suffering from migraines but not diagnosed with MS?
Yes and no. So essentially, they're treated just the same as we treat any other pain. With pain, and we'll talk about the treatments of pain in a little bit. Yes, but migraine, headache, there are two ways to treat it. Either you stop the migraine or abort it, or you prevent it. And the idea is to try to prevent it. The medications to prevent it are very similar to the medications that we commonly use. In the last couple of years, there have been some brand new monoclonal antibody treatments for migraine. Now, these treatments are very specific. They are specific in their way of mechanism of action, and so that they have fewer side effects than some of the treatments that we typically use. One of the downsides of these monoclonal antibodies is that they're very expensive. So take heart, migraine sufferers whose insurance may not be able to cover these new treatments. Yes, the treatments that we've been commonly using are good treatments for migraine headache.
Lucy is also watching, and she writes, "I live with MS and diabetes and experience painful pins and needles in my feet. How can I tell if these symptoms are related to my MS or to my diabetes?"
Lucy, that's a good question. So the diabetes kind of pain is called peripheral neuropathy, meaning damage to the peripheral nerves outside the brain and the spinal cord. MS pain, which is felt exactly the same, is coming from lesions in the brain and in the spinal cord, central pain. How do you know the difference? Lucy, you might know when your blood sugar is under control, your feet and your legs may not have the same burning sensation when your blood sugar is under control. That's one way you might know that you're dealing with a peripheral neuropathy. Your neurologist or your provider can do some good history taking, and they can do some studies like nerve conduction studies to determine if the pain is peripheral or central. But Lucy, it doesn't really matter because the treatments are exactly the same. That whether you have central pain or peripheral pain, the treatment's the same. So take heart.
Well, that leads us to our next question from Tanya, who writes, I've tried everything my doctor has advised me, but I'm still struggling to consistently manage my pain. I feel like I'm on a roller coaster of ups and downs, and I don't know what to do. Dr. Maloney, what is it about managing pain that makes it so challenging?
It is challenging. It is challenging because it's different for each individual. And what's good for one person is not good for another person. Part of the difficulty in managing pain is expectations. The provider's expectations, like my expectations that the med I prescribe is going to work, and it may not. And then the patient's expectations that, gosh, if I just get the right medicine, that's going to work. And the trial and error, and this is, I think, what Tanya meant by the ups and downs, the trial and error of medicines. My suggestion is a couple of things. To have a good conversation with your neurologist or your provider on the pain management. And it's a multi-pronged approach. It's not just drugs. It's also a combination of drugs and other mechanisms that help minimize, like increasing your activity level, thinking of mindfulness techniques, of doing some yoga, other things that might manage pain that are not medications. And I think we'll talk about that. John will probably ask me a question later to further explain that. Expectations, it's not, the pain is your pain. The person who's suffering the pain, that pain belongs to them. And it's not going to be necessarily taken away by a medication or by the doctor. Trying out a drug more than just a couple of weeks. And I know my patients, when I give them a medication for pain, and as soon as they start having side effects, they want to stop. So it's a real long process to get on the right drug. And take that time, because it's really important to see what works. Take over 3 months. It sounds like a crazy amount of time, but take 3 months to stay on a drug before you decide that this drug is the wrong drug, it's not working. Go low, go slow, build that drug up over a month, over 2 months, over that 3 months to the top dose. Don't hurry, it's not a marathon. Pain is with you for a long, long time, and it's gonna take a while for action.
Well, we've touched on medications a few times, and we should probably take a deeper dive into that now, because we actually have several questions that I'll sort of bundle together and let you address collectively. Karen is asking, are there safe, non-addictive medications to help treat pain? Several people have asked, what are some of the common medications used to manage pain? And Jim wants to know if CBD or cannabis is an effective way to manage his neuropathic pain. So hopefully you can shed some light on CBD or cannabis-based products as well. But help us understand better what medications might be available.
Okay, yeah, let's start there, John. So several medications, and these are classes of medications. There are oral medications and there are topical medications. Topical would be things like lidocaine patch, lidocaine ointment, capsaicin or hot peppers. This can help manage pain, some of the topicals. The oral medications can be grouped as anti-epileptic drugs, drugs that are commonly used for seizure control. But pain is almost like a seizure. It's that wild, erratic firing of nerves that wears down neurotransmitters and can cause pain. So that's why anti-epileptic drugs, and I'll name a few: gabapentin, which is Neurontin, pregabalin or Lyrica, can help with neuropathic pain. Topiramate or Topamax. Topamax is a great drug that can help migraine headache sufferers. All of these drugs, of course, have side effects. Carbamazepine is a wonderful drug that is a premier drug to help trigeminal neuralgia, that sharp, lancinating, stabbing facial pain. Carbamazepine. The watchfulness there is that you have to watch your sodium levels, because sodium can get very low and cause weakness. So if there's a quick onset of weakness, you might look at your carbamazepine and drugs to see if that's the culprit. antidepressants are also important in managing pain. Not so much for the antidepressant, but obviously that is helpful, but because they actually work to encourage those feel-good neurotransmitters that I talked about earlier, serotonin, norepinephrine, dopamine in the brain, to modulate the experience of pain. So pain is felt, it enters your body, enters your brain, and your brain, you know, when you say pain is in your brain, yes, it is. It's in your brain because your brain registers that pain. And then the experience of pain is dealt with either with more pain or less pain, depending upon the neurotransmitters in your brain and how you feel about it. So those are some of the treatment options that are medicines for pain management. Other antidepressant class that might be really good to try at night are tricyclic antidepressants, amitriptyline and nortriptyline. And the reason I mention that they're good at night, because they also have the side effect of stopping your bladder from being so overactive at night. So you're not getting up a couple of times to go to the bathroom. So it's a little bit of a drug that's a twofer. So it might help with your sleep and your rest and your pain management if taken at night. So those are the treatment options. And then your second question, John, was, it wasn't the cannabis. There was one in between. Just remind me.
Well, no, the second one was to talk about some of the common medications to manage pain, and you just did that. Okay. So maybe we can drill down to Jim's question about CBD or cannabis-based products. Okay.
So that's a great question, Jim. And there was a recent study that looked at people with MS and their use of cannabis. And probably about 50% of people with MS use marijuana to manage symptoms. It may not just be pain, but symptoms in general. And 48% of those people have a medical marijuana card. So that helps me drill down to, you know, marijuana. Now, I work for the federal government, so it is totally illegal. I have to abide by federal laws that still declare that marijuana is a Schedule I drug and totally illegal to prescribe, to grow, to promote, to procure. So for me, I would never hold back treatment of one of my patients with marijuana. And I talk about the pros and the cons with them, but I can't prescribe it. If you have a medical marijuana card, it states that do prescribe, that's fine. I think the conversation between you and your provider about whether that's managing your pain is important, because what we don't know a couple of things. We don't know what the side effects over long term are going to be with marijuana, because there have not been good research studies. We need some better research studies, and the National MS Society is promoting better research and hoping that we can get more research in MS and the use of cannabis. When you have a marijuana card and you go to the vendor who supplies the cannabis, you may not always know the exact concentration of CBD or THC that is in that medications from vendor to vendor or product to product. It may vary, and that's important, because you may have a reaction. Now, as CBD is the non-psychoactive component, it is slightly addictive, but not like THC. When I say addictive, dependent, causing dependence, and it can cause some sleepiness, CBD. So if you're oversleepy, and like one of my patients' wife called me and said, I can't wake him up. He had just had some medical marijuana that he got from a vendor, and he felt that maybe doubling the dose was a good idea, but it took 24 hours for him to wake up. So that's a cautionary tale. And so I suggest CBD and THC, which is the psychotropic portion of marijuana, should be used with great caution. There was a study out of Canada several years ago looking at smoked marijuana. And they looked at the cognitive function of people smoking marijuana and realized that there was a global decline in cognitive function with smoked marijuana. So that's a caution there. So, John, what I would say is evaluate, and the other thing is what we haven't done is we haven't evaluated marijuana compared to gabapentin or amitriptyline or duloxetine, venlafaxine or Effexor, some of the other medications we use for pain. There've never been head-to-head trials, so we don't know whether one is better than the other. And those are all questions we need to ask. So, John, I would go to your provider. I would make sure that your provider knows that you're using medical marijuana to manage your pain, and ask him what are the side effects? Is it going to interfere with anything else that I'm taking? And that's a conversation you need to have.
A moment ago, you mentioned the experience of pain. Pain isn't a purely physical experience. I'm wondering what you can tell us about the impact of pain on someone's emotional well-being. What kinds of things should people be aware of? And is there a relationship between pain, fatigue, and mood or depression?
I would say absolutely there's a relationship. It's almost a circle. It's almost a vicious circle. So pain wears you down, right? It wears on you. It's constant. I had a patient yesterday say that he has tingling and numbness, and not that that's so painful. He says, during the day I manage okay, but at night when I'm lying down, it's so much worse, and it wakes me up and I can't sleep, and it becomes nagging and it overwhelms me, and all I think about is this tingling that won't go away, and that happens. That nagging and that ability to wear someone down almost becomes a catastrophe, and that kind of thought in a person's head, where they can't get rid of the thought or they can't get rid of the catastrophe, makes it worse and worse. It's kind of like you're stuck in traffic and you're going to be late for work. And the more you are stuck in traffic and the more you worry about what's going to happen when you're late for work and the ramifications of that, you get more and more concerned and you break out into a sweat, and then pretty soon you have to go home and take a shower. All kinds of things happen. But that's what I mean by catastrophe. So that's mood. That's how mood is affected by pain. Pain becomes a catastrophe and your mood's affected. Or you become depressed because you isolate. People who are in pain are cranky, and people around them don't want to be around them. So either they isolate because people don't want to be with them, or they isolate because they don't want to inflict themselves on people. And that's sad. That's very sad. So that is where depression can occur. And fatigue, all that pain and all that worrying about pain completely causes increased fatigue, and then fatigue can cause more pain. Mood can cause the pain to be worse. So again, it's a vicious cycle that we have to get out of.
I've heard you a few times actually mention how important it is to be communicating, to talk with your doctor about pain. Darla has asked, she writes that she's having a hard time getting her physician to understand the level of pain she's in. She feels like giving up on seeing this physician, wants to know how to work better with her doctor. So what's the best way for someone to work with their doctor in managing pain?
That's a great question, Darla. And indeed, the only way is through a partnership with your provider, because it's very difficult for you to do this alone. So I would create a diary. I would write down so to make it easier for the provider. So when you get there, you're making your visit more efficient. You only have a certain amount of time with that provider, maybe 15 minutes, which is nothing, maybe 30, which is, you'd be lucky. So make it easy, write a diary. When does this pain occur? And I often use the acronym OLD CART. Onset. When was the onset of that pain? Write that down and write when it happens more often, so that the provider can understand, oh, this is really just happening at night. Oh, this is happening in the morning. And what are the circumstances around those times of day? Location, OLD CART, location. Where is your pain? Is it in the legs? Duration, how long does it last? Is it constant? Does it vary in severity or intensity? What is that intensity and severity? Even write a little pain analog chart, 1 to 10, and put some numbers on there over time. And that helps track your pain. That's a really good mechanism. So if the doctor then gives you some treatments for that pain, take a week and then make another line on that chart where you are. Are you closer to 5? Are you closer to 4? 10 being the worst pain, 0 being no pain. So help your doctor out by doing a little bit of homework. The CART part is characteristics of that pain. Is it burning? Now, these are very important because this helps with treatments. Burning pain is treated very differently than sharp pain. Tingling pain may be treated differently than lancinating facial pain. So we want to know exactly the characteristics of that pain. What makes it worse and what makes it better? A stands for aggravating factors. R stands in old CART, relieving factors. And that's important to know too, because you yourself then can capitalize on the aggravating. If having an argument with your children about doing their webinars, now that it's COVID, they're on webinars. If those arguments make your pain worse, take yourself out of the picture. Get your husband or get your neighbor or get an older sibling to monitor those education sessions online. Relieving symptoms, what makes it better? Does getting a good night's sleep make it better? Probably. Do you have to get up to go to the bathroom several times? How can you manage that? Maybe a little amitriptyline at night or nortriptyline can keep you out of the bathroom at night. So look at the relieving factors. And then what are the other treatments that you're using? The T part of old CART are you using cannabis? This should be known by the provider so that that person can put it in the mix. If this doesn't work for you after a while, maybe you might seek in that office setting another provider. But your provider wants to work with you. They may not know that it's not working. So you have to let them know. So you're in charge, you let them know.
Well, thank you for sharing some very helpful insights, Dr. Maloney. I'd also like to talk with you about managing fatigue in MS. But before we get into that conversation, I want to take just a moment to welcome those of you who have continued to join us on GoToWebinar, Facebook Live, and YouTube Live. Please let us know what's on your mind. Post your comments and questions on Facebook and YouTube, or type them into the questions box if you've joined us on GoToWebinar. Our Ask an MS Expert live event takes place at this same time every Friday. So please help us make sure that everyone knows about it by sharing news about the webinar with your family and your friends. I'm talking with Dr. Heidi Maloni, who's been sharing some really helpful information about the impact of pain in MS and how to best manage it. Now I'd like to talk about another invisible symptom of MS, and that's fatigue. Fatigue has been cited as one of the most common symptoms of MS. It can significantly interfere with a person's ability to function at work or at home. Fatigue may be the most prominent symptom for someone who otherwise has minimal limitations on their activity. Some people with MS say that family members, friends, coworkers, or even employers sometimes misinterpret their MS fatigue and think they're either depressed or just not trying hard enough. For example, we've already heard from Clara, who says, "I'm beyond frustrated with my husband who doesn't understand why I can't be outside watching our kids play sports and not doze off while watching them. He says it shows I don't care and that I'm not interested in being with them. And that's far from the truth. I just can't help it. As the heat rises and the day progresses, it's like my body shuts down and I can't control it. With this COVID pandemic, being outside is all that my family looks forward to. And I don't want them to feel that I don't care. Any advice would be appreciated." So before we get to some specific advice for Clara, Dr. Maloney, can you first explain the kinds of fatigue associated with MS, the causes of fatigue, and how heat impacts fatigue in MS?
Okay, so let's start with the common types of fatigue in MS. And I like to liken it to a sonata. A sonata has three parts to it until it comes to a possible crescendo, right? So a sonata, the three parts. The first part is fatigue is actually coming from a lesion in the central nervous system. It's physiologic. There is a cytokine expression in the central nervous system. There's demyelination. There are parts of the central nervous system that are affected and cause physiologic fatigue. So that's sonata part one. Part two are some of the other physical things, deconditioning or weakness. Deconditioning, you're going to have more fatigue because it's harder to do things. The effect of heat, and I'll talk about that again. Respiratory problems, maybe not being able to take a deep breath, and that it can contribute to fatigue. Then my last part of the third part of the sonata is all the other stuff. And what do I mean by all the other stuff? Depression, mood, these all impact fatigue. Medications a person may be taking, antihistamines, which are very commonly prescribed, almost willy-nilly, and people take them forever, even beyond the spring and the fall. Those are huge fatigue-related medications that I don't think people are totally aware of. Other medications like antispasticity medications, antidepressants, antihypertensive medications, these are all promote fatigue. Infection, and you mentioned heat. Poor sleep, lack of sleep, inability to go to sleep, inability to stay asleep, are all hugely promoting fatigue. And then lastly, nutrition. I always think of, what's your nutrition? Are you eating meals on time? Are you eating proper meals? Are you snacking a lot? Are you hoping that maybe that candy bar is going to give you energy? And at 4 o'clock in the afternoon, when you're completely depleted, you've got a whole sleeve of Oreo cookies down in the tummy. And of course, that doesn't help with dinner, because then you're not wanting much dinner with a sleeve is a serving, you know, right, of Oreo cookies? Not. So at any rate, nutrition and good fluid balance, making sure you're drinking fluids and drinking things with electrolytes in is also helpful. So then let's go to your other question, John, about heat. Heat is totally debilitating for people with MS. Heat in any form. It can be ambient temperature. We've got summer right now, and I had a patient this morning who said, this heat is killing me. I feel like a loose noodle. I feel completely wiped out. I have absolutely no energy. I went out on my patio to have dinner with my girlfriend, and we kind of dressed up, he said, so that would make it special, because he's in COVID, so he can't go to a restaurant. He said, I just melted. I had to go in. I couldn't even bring my fork to my mouth. I was so exhausted. So why is that? Well, you know, what is that? What is that? There's a name for it, and it's called Uthoff's syndrome or Uthoff's phenomenon. So named by a German ophthalmologist who was noticing that there were changes in the eyes of people with MS when they were hot. And in further explanation, there is actually when the nerves, the axon on the nerve has some of its myelin stripped of it, and it's having a hard time with nerve conduction as it is, the heat actually limits that nerve conduction. Taking a person out of the heat immediately puts back the nerve conduction and resolves the issue. Exercise can cause heat, right? We all know that. Exercise can heat up the body, and after a period of exercise, someone may feel more fatigued. Other questions? Did I answer all of them, John?
Absolutely. I'm curious, how can someone tell if their fatigue is related to MS or something else?
Oh, that is a good question. Yeah, what you all remember that before you were diagnosed, if you went to the gym and exercised, or you had some exercise, that you felt tired, but then you recovered. MS fatigue often is, people don't recover, and they feel tired all day, and tired more as the day progresses, and maybe tired without exertion. You may be tired when you wake up in the morning. So that, in a sense, that's the difference, you know, fatigue without activity and fatigue with activity. I think that I answered that question. Have I answered Cora's question? I would like to get back to that, or is it a chance to do that?
No, we're definitely, actually, this would be a good opportunity. That's fine. Sure.
Yeah. Yeah, okay. So Cora, your concern is going out and playing with your kids. And I can't hear you, John. Were you talking to me?
No.
Can you hear me?
Yes.
Okay, I'm sorry. So you bring up a good point, Cora, about going out and with your kids. And we just talked about heat. And the heat is overwhelming you and causing you to fall asleep during the activity. One, it's the heat. Two, you're not involved. You're probably on the sidelines watching them. And it's easy to kind of get your mind off subject and to wander and to fall asleep. It's nice and warm. Keeping yourself cool will help, and we'll talk about strategies, wearing a cooling vest, a cooling neckband to go out, a hat, absolutely a hat, and sunglasses. All of these cooling techniques when you're out with the kids. But making you the object of the game. Maybe you could be it. So they have to come to you to tap you. Maybe they have to throw the ball to you. So in that outdoor environment, it's in your yard. Think of a game that involves you as the center of attention. The other thing is you can take the outdoor activity to another venue, to a pool or a lake, or maybe a boating situation so that you can have some family fun, still maybe distance, and be able to do that. There may be some trails that are wheelchair friendly that you could be on, and hiking in a cool woods environment, hiking or trekking in a cool woods environment with a family is another option. So two things, making sure you're cool and making sure that the object of attention somewhat centers on you so that you can be part and not just an observer of the activity. Back to you, John.
I think you started to answer my next question as it relates to Clara, and maybe we can talk about it a little more broadly. Perhaps you can share some strategies to best manage MS fatigue.
Sure. One of those strategies is energy conservation. You don't need to do everything at once. You kind of stretch it out during the day. Taking frequent rest periods, rest and restore, making sure you're getting good sleep, but energy conservation and then resting and restoring. Think about how you can pass on activities to someone else. Can someone else pack the lunches? Can someone else make the beds? Can someone else pick up the socks off the floor and put them in the laundry machine? Can you trade a job with a neighbor? The kids can come over and play here if you take them to school, or you bake the cookies for the soccer team, or whatever you need to do. But think about your day. Think about how you're going to manage that day and conserve your energy. Power naps are always good. Maybe setting a clock for 10 minutes, fall asleep, and allow yourself to wake up. Cooling, another technique, making sure you are cool. One of the best ways to bring heat away from your body is through convection. Take a spray bottle like you'd spray a plant with, put it in the fridge or even the freezer for a while, get it nice and icy cold, and then spray your face, spray your neck, spray your arms. And Clara, you can do this outdoors. You make sure you're spraying yourself to convect the heat off of you. Wearing a cooling vest. Polar Tech is one of the vendors, but there are many vendors that make cooling products. They also make cooling products for your neck, cooling hats, making sure you have some of those things on. Fans when you're exercising can help. And then exercise, and we will talk about exercise and how to do it properly, but when you do exercise, make sure you're using your spray bottle and maybe having a fan handy so that you're exercising in front of a way to cool yourself. Other ways of managing, other strategies are medications. So we can talk about medications at this point. John, you may be asking me about that.
I think we should. What medications might commonly be used to help manage fatigue?
Yeah, so there are several classes of medications that can help manage fatigue. An old medication that's been used for years and has some effect on fatigue. And remember, if something doesn't really work for you, you can switch it up and just make sure you have a conversation with your provider about this. But it's amantadine. And amantadine is an antiviral medication, and it's also used in Parkinson's disease to increase dopamine in the brain. So that increased dopamine is energy provoking, so it can help with energy. So amantadine is one. Then there are some central nervous system stimulants, and one of them is modafinil. Another class is methylphenidates, and another class is amphetamines. So those classes of drugs, and they all, of course, have side effects that you need to be concerned about and have a conversation with your care provider about. Modafinil is probably the safest of those central nervous system medications. Antidepressants are also helpful aside from their antidepressant effect for fatigue because they increase those neurotransmitters and specifically dopamine. So those are strategies for managing.
I'm wondering, are there emotional aspects associated with how fatigue affects an individual?
Yes, indeed, of course. Mood, anger, depression, all of those are going to make your fatigue worse. It takes a lot of energy to be depressed. And that expenditure of energy impacts fatigue. And then again, the vicious circle where fatigue can increase depression because you can't exercise with fatigue or it's difficult. And we will have talk about strategies for exercising. The lack of exercise impacts depression and impacts mood and impacts fatigue even more. So yes, those are all intertwined and need to be addressed.
I'm wondering what kind of healthcare provider can best help someone manage fatigue, and how does someone best partner with that healthcare provider to identify the factors contributing to their fatigue?
Good question. I would say off the top of my head, physical therapists would be a good way to start to manage your fatigue because they would show safe mechanisms for activity, increasing your activity levels. It has been studied that increasing exercise absolutely helps with fatigue if done in a specific and programmed way. And physical therapists are best at managing and helping with that program. Nurse practitioners in the office can also be great resources because they have the time. They're able to connect with people. They understand the fatigue and the symptoms, and they can offer strategies.
Well, Dr. Maloney, you're the recipient of the Paralyzed Veterans of America Nurse Award for exceptional service to veterans with spinal cord injuries and disorders. And you earned a commendation from VA Secretary Robert McDonald for excellence in patient care. So I'd like to talk about VA services for veterans who are dealing with MS. Are there any specific programs or resources that our veterans should be aware of?
Absolutely, John. But do you mind if I go back to one other thing about fatigue that I didn't hone in on it specifically, and that was exercise? I want to answer that question. And thank you for all the adulation. Hooray. But I absolutely want to talk about exercise because it's so important. And there are folks that are going to say, I can't exercise because it just wipes me out. But there's a strategy to that. And it should be done every other day and no often than every other day. It should be done. You're not a weekend warrior. You don't need to start at the high repetitions and the great exercise. You need to start with some stretching and maybe some resistance training, a little bit of weightlifting, and then maybe some aerobics, slow walking or cycling, and doing that for 5 minutes, increasing it to 10 minutes until you get up to the ideal, which would be 20 to 30 minutes every other day would be the ideal. And that can be done with a physical therapist. And I probably should have mentioned all of that. But now let me just transition to the veteran part. Because I have veterans very near and dear to my heart, and I hope some of them are watching our program today, and they know that. So we have a partnership with the National MS Society, the VA Multiple Sclerosis Center of Excellence. A year ago, formed a public-private partnership with the National Multiple Sclerosis Society. Veterans have gotten a lot out of that because the NMSS, your Multiple Sclerosis Society, has offered programs, the MS Navigator program, and education sessions like this and other webinars and your website that are very beneficial to people with MS. Our regional programs for the MS Centers of Excellence have also partnered with local MS societies to offer on-site people from the MS Society to come to the clinics to answer questions and to help. Our veterans that are service connected have great resources in the VA to manage their MS and their disability. But veterans who are not service connected need the help of the MS Society. Their caregivers need that help. Their families need that support. So yes, that's how we've managed to partner and make the most. 1 and 1 is 3.
That's great. Well, first, thank you for providing all of these insights. They've been incredibly helpful. And I'd like to address more of the questions that our audience has for you. Jack notices that when he's really fatigued, not only does he feel physically exhausted, but he feels he cannot think straight, gets like brain fog, and it makes work challenging. He wants to know if this is typical.
Yes, Jack, it's typical. It's not just physical fatigue. It goes hand in hand with cognitive fatigue. Physiologically, remember the sonata that I talked about? Physiologically, there is activity in your brain that's causing just that brain fog that's related to lesions in your central nervous system. And all the other parts of that sonata where you're the deconditioning, the weakness, the difficulty pulling legs through a gate, the physical difficulty, the expenditure of energy is also going to cause cognitive fog. So the answer is yes. And the strategies that I mentioned that can help with the physical will also help with the cognitive. Specifically, frankly, some of the central nervous system stimulants definitely help with cognitive ability and are important to keeping you on the job, keeping you in the workplace.
Now, a few minutes ago, you were talking about the connection between mood and fatigue, and Megan writes that since her diagnosis, she feels tired all of the time. She also feels very sad. Well, she wanted to know whether MS fatigue and mood problems are related, and I think you've answered that certainly. But then she had a follow-up, wants to know, how do you sort them out so you know which to treat?
Megan, you're a genius. That's a great question. And I would go to a professional to sort that out. I would have your provider refer you to mental health, have them do a great assessment, which is what mental health does do, and see if depression is the cause, or fatigue is the cause, or maybe they are interchanged, and then treat them. And I think that's my guidance would be go to some professionals for help.
Well, if we can talk a bit more about pain, we've got some questions coming in. Darlene wants to know what to do when she experiences the MS hug. Well, first of all, you can explain what the MS hug is and how do you make it go away?
Oh, so the MS hug is literally what it sounds like. It is what it sounds like. It's a pressure or a constriction around the rib cage. And it occurs because of lesions in the central nervous system. And it occurs also because of spasms in the muscles around that rib cage. There's muscle contraction that occurs. And so it's a combination of increased spasticity causing that pain and some of the lesions. So we treat it very commonly as we treat any pain that I've talked about, with medications and with non-medication therapies, stretching and yoga, topicals, sometimes a lidocaine patch, or constriction, putting on an abdominal binder, a tightness, a feeling of, you may feel, why is tightness going to help? But actually may offer some comfort to be constricted or bound. You remember if you were to sprain a muscle, the rest, ice, compression, elevation are all parts of those things. I'm not talking about rice for the MS hug, but certainly compression. You can try cold and heat, and that might also be a strategy that you can use. But it's all about strategies in your tool chest, not just medications, but other strategies that I've just mentioned.
Allison, yes, go ahead.
Can I just quickly, I mentioned it as a spasm. So anti-spasticity medicines are also important. Maybe baclofen or some of the other medications that are used for spasticity may help too. Thanks, Megan.
Thank you. Allison writes that she experiences severe pulsating pain on one side of her face, which makes it hard for her to eat or even talk. So she wants to know what she can do about facial pain.
Yeah. So Allison, this is tough. And I imagine your facial pain comes and goes, is very sharp, one side of the face, you just said. And the strategies for managing that are usually medications, or only medications, frankly. Yeah, it keeps you from chewing on that side. It keeps you from the fear of that pain, because it can be so excruciating. Probably keeps you from brushing your teeth. Maybe even fear of someone coming close and kissing you or breathing on you is a fear because of the pain. So carbamazepine or Tegretol, oxcarbazepine, but carbamazepine specifically is the drug of choice for trigeminal neuralgia, which is what you're describing. And I would maybe categorize it as trigeminal neuralgia, but that's a diagnosis I don't want to make. Your provider really actually needs to assess well and make that diagnosis. But medication therapy is probably the strategy you need to go for.
Monica is experiencing painful muscle cramping, usually at night, and she wants to know whether this sort of pain is related to her MS.
Maybe, maybe not. People get muscle cramps for lots of reasons. Often they are dehydration, possibly mineral or electrolyte problems. Have your provider draw a chemistry panel and look at your sodium levels. Maybe some increased magnesium or potassium, sodium. Drinks like Gatorade, or I don't want to say products, but electrolyte drinks can help. Pedialyte, that's a product, sorry. But maybe those will be helpful for you at night, making sure that you're not dehydrating. You know, MS is tough because of the bladder issues. You kind of want to stay away from water, because what does water make you do? Go to the bathroom, right? So that urgency and frequency and the near misses make people want to stay away from water, and that's not a good thing. So little sips of water are very helpful, and especially water or electrolyte mixes before bedtime might be helpful.
Sue is experiencing what she describes as electric shock sensations on one side of her body. She feels them over and over throughout the day, and she's wondering whether this could be a type of MS pain.
It sounds like it, Sue. It sounds like that these electric shock-like sensations are MS pain, because you're describing them as something that's not normal, right? So a paresthesia or a dysesthesia, something that's a experience that's painful. I would say it's related to your MS. I would talk to your provider about ways of managing that with both medications and non-medications. So pain is best managed with a combination of both of those.
Karen acknowledges that she gets a lot of weird and painful sensations throughout the day, things like severe itching, crawling sensations, and sometimes feeling like her feet are on fire. She knows these are related to her MS, but wants to know beyond that, what is causing all these different kinds of sensations?
Right. So this is a great question. It's not common, but every once in a while, someone will come to me too and say, I've got this intense itching. But again, that's a dysesthesia. That is an abnormal sensation. It sounds like it's fairly constant, even though it might be more intense and less intense throughout a day or a period of time. And it is thought of as pain, as an MS pain syndrome related to a lesion in your central nervous system. So again, you're going to treat it with either anti-epileptic drugs and antidepressant drugs, those sorts of drugs that are used for treating dysesthetic extremity pain. That's a nomenclature that I hadn't mentioned before, but that's exactly what that is, and that's what it's called.
Well, I want to thank everyone who submitted their questions, and thank you, Dr. Maloney, for being with us today. I think that—
Thank you, John.
Oh, of course. I think that one of the best things that anyone can do for themselves, especially during these uncertain times, is to make sure that the information they're getting is credible and reliable. So we'd like to share some resources with you. And these are resources that you can count on to be current and credible. You can always check the Society's website at nationalmssociety.org/COVID-19 for complete updated information on COVID-19 and MS. And I want to circle back to something I said earlier. If we were unable to get to your questions today, please know that the National MS Society's MS Navigator team is available to answer your specific questions and connect you to the very best resources. I'll share all the ways that you can contact an MS Navigator in just a moment. The VA Multiple Sclerosis Centers of Excellence are dedicated to furthering the understanding of multiple sclerosis, its impact on veterans, and the most effective treatments to help manage MS. For more information on their services, please access their website at va.gov/MS. I'd also like to acknowledge that we are in the midst of an emotionally difficult time for so many people, and I want to make sure that you're aware of some resources that are available if you find yourself in emotional crisis. The National Suicide Prevention Lifeline is available 24 hours a day, 7 days a week. They offer free and confidential support for people in distress, as well as suicide prevention and crisis resources for you or your loved ones. And you can reach them by calling 1-800-273-8255. That's 800-273-TALK. And I'll remind you that every week on the Real Talk MS podcast, I continue the conversation that we start here. So I hope you can take a few minutes and give Real Talk MS a listen. You'll find the Real Talk MS podcast at realtalkms.com, Apple Podcasts, Google Podcasts, Spotify, Pandora, or wherever you find your favorite podcasts. We're all witnessing that even during a pandemic, MS doesn't slow down, and it doesn't stop, and neither does the National MS Society. This webinar is just one example of how the MS Society has created virtual programming on the fly so that no one has to face MS alone. They've also created virtual support groups, provided resources and information about COVID-19 so that people affected by MS can get answers to their questions, and healthcare providers can deliver the very best care to their patients. The Society continues to amplify the voices of the MS movement to influence critical public policy decisions, and they never stop advancing the research that will find a cure. The National MS Society's COVID-19 Response Fund has been established to ensure that the Society can meet the urgent and expanding needs of the MS community during these unprecedented times. And I'm asking you, as you're able, to support the MS Society's work by making a donation to the COVID-19 Response Fund. To donate, you can text the word GIVE to 68686, and you'll get a link right to the MS Society's COVID-19 Response Fund webpage. Or you can point your browser at the URL on your screen and make your donation that way. So however you choose to contribute, by texting or visiting the donation page on the Society's website, please contribute today. It's never been more important. Speaking of important things, I promised that we'd share all the ways for you to contact an MS Navigator with your questions. You can find them on the MS Society's website at nationalmssociety.org. You can contact an MS Navigator by phone at 1-800-344-4867, or you can email your question to an MS Navigator at contactusnmss@nmss.org. You can also connect with the National MS Society on your favorite social media channels, including Facebook, Instagram, Twitter, YouTube, and LinkedIn. And when you do, please make sure to like those social posts and subscribe to those social channels. And you want to make sure that you get on the Society's mailing list by signing up at their website. That way, you'll receive regular updates on upcoming programs and the latest information on MS treatments, research, and how to live the very best life with MS. I'd like to thank Dr. Maloney once again for sharing her insights and expertise with us today. And I'd like to thank everyone who's joined us for your great questions. Please remember that a recording of this webinar is going to be available for your review on the Society's website at nationalmssociety.org/MSexpert. Now I have a quick favor to ask each of you. Getting your feedback on today's webinar is important. So you'll see a survey pop up in a moment when we close out the webinar. And if you happen to be watching on Facebook Live, you'll see a link to that survey pinned to the comments section. And on YouTube, you'll find that link in the program description. Completing the survey makes a real difference. The information you provide helps us improve, and it helps shape future webcasts. The survey takes 1 minute, and it can make a difference, so please take that minute to fill it out. On behalf of Dr. Heidi Maloni and the National MS Society, I want to thank you once again for joining us. Please stay safe and make healthy choices.